My name is Frank Caligiuri, and I'm an assistant professor here at Drake's College of Pharmacy and Health Sciences. And I'm going to be serving as a speaker as well as the moderator for today's panel session. I'm going to begin by introducing our panel. I'm going to begin with some colleagues from the College of Pharmacy and Health Sciences as well. At the far left of the table, we have Dr. Craig Redden. He's an associate professor of pharmacology, and he's also the department chair the chair for the Department of Pharmaceutical, Biomedical, and Administrative Sciences. And also to the right of him is Dr. Sarah Grady. Sarah Grady is also a clinical faculty member, an associate professor in the College of Pharmacy, and she maintains a clinical practice site at Broadlands Medical Center, where she works specifically with patients with mental health disorders as well as substance use disorders. And finally, we have Mr. Dale Woolery, an associate director from the Governor's Office on Drug Control Policy, and so he's going to begin the panel. We have a lot to cover in just an hour here with you guys, and so in the interest of time, I'm going to go ahead and turn it over to Dale to begin the session.
Thank you, Frank. And thanks to all of you. I appreciate the opportunity to be here. I'm kind of the outlier because I don't come from the School of Pharmacy, although I visit my pharmacy a lot. The older I get, the more I visit my doctors and my pharmacists. I'm going to provide some quick snapshots of where I think we are in the state of Iowa and some context as it relates to this country and not so much the global perspective, but it is a global issue, and it's one that the opioid issue cuts across so many different areas. So it does touch on the environment as well as health, public safety. So you have healthcare, education, law enforcement, and so many other entities. So I'm going to jump right to it, try to get through this and stay on time, and hopefully we'll have time for questions later. This is a heat map that simply shows the growth of opioid abuse in the United States over the last decade or plus. And the more red means we have more. We're losing about as many lives a day to opioid overdose in this country as you would lose in an airline crash. But since it's not an airline crash, we don't hear about it like we would an airline crash. But a lot of lives are being touched and tragically being lost. This is the Iowa version of the same heat map we saw for the nation. We've had growth here. The good news is that the problem didn't start as high, hasn't grown as fast, and we're not to the crisis point that the other places are. But I don't want to sound like I'm in denial. We do have a growing problem. And while we started at a lower point as it relates to opioid abuse in the state of Iowa compared to many other states, our rate of growth or increase is pretty much the same. It's on the same trajectory. And I should back up. When I use the word opioid, because we had this discussion earlier, I use opioid as an umbrella term to talk about prescription pain relievers, plus the illicit drugs such as heroin, plus the newer synthetic opioids, the non-medical synthetic opioids, which would include fentanyl analogs that are not pharmaceutical grade. They're not prescribed, they're not dispensed in a pharmacy. They're made in Asia, they're smuggled in, and they're used to cut heroin, and they're killing people. So we have three different varieties as I look at it: prescription, heroin, and now this newer kind of in-between, it's a non-medical synthetic that technically is not illegal in our state right now. This is another one of those where the laws are going to have trouble keeping up, so it's up to all of us to keep up. The connection between prescription painkillers and heroin is simply a chemical connection. They're the same thing. It's just that one's regulated and dosed and overseen by healthcare professionals, and the other is made by cartels and is not regulated. It's simply for profit. But a lot of people who start with prescription pain medicine wind up using heroin. Not everyone, but it greatly increases the odds that someone will go on to use heroin if they first become abused to prescription painkillers. Why do people go on to heroin? It's economics. It's cheaper, and it may be better, as some of the users may view it, especially those who are addicted to opioids. These are the prescription drugs kind of in the order of volume and also abuse, nationally and in the state of Iowa. And this is some of the context I'm talking about. We're in the middle of the pack when it comes to the number of opioids, the prescription variety being prescribed, and also on the rates of abuse. I think overall we have the 13th lowest rate of opioid abuse of all states in the United States. But again, we can't rest on our laurels. We want it to be lower than that. Too many lives are being lost. This just shows people in Iowa going into substance abuse treatment, their drugs of choice, so their primary substance of abuse. That other category includes opioids, non-heroin opioids, because that's not a category that has really been anticipated in years past. So even the reporting systems don't really do a good job of capturing this, but other includes the synthetic opioids, and it also includes other synthetic drugs. Difficult to see, but I guess importantly, two of the lower lines here include some of the prescription opioids and heroin. And they're really low compared to other things. What you can't see here because of the way it's indexed, while we're seeing a decrease in the use or abuse of some substances, we're seeing an increase in those. So while they start low, this is one of the emerging trends that we're trying to get under control. Youth, similar story. The number of Iowans in 6th, 8th, or 11th grade who are misusing prescription or over-the-counter medications has remained steady at 3 or 4%, depending on what we're talking about. So it's not a huge number, but it's remained flat. And again, before 2005, this wasn't a thought. Iowa youth weren't even being asked about this issue. So we don't know what was going on before then. We have an increase in drug-related fatalities. Now, this could be any drug, but we believe a lot of it is being driven by prescription drug impairment. We don't know because, again, systems are not in place. We cannot test as well for prescription drugs as we can for the illicit drugs. Law enforcement officers who are drug recognition experts report 100 different times last year where narcotics were involved in stops of drivers. I want to point out the brown section of this pie chart. It's showing that in the workplace, companies that do drug testing of employees, back in 2002, a little under 10% of those employees tested positive for opioids. That increased a decade later to almost 13%. So it's one of the few areas where there's actually been an increase. And again, testing is limited because it cannot test as effectively. Emergency room visits, obviously, upward. Substance abuse treatment admissions, a lot of these trend lines are kind of headed in the same direction, if not any given year or 2 years, at least over the last multiple years. And pharmaceuticals are driving a lot of the calls that go to the state's poison center. Now, some of this is my dog ate a pill, and what do I do? But a lot of it is people, children, and in some cases they actually have drug dealers calling and wanting to know what the medicine is worth. And they've heard drug deals go down when somebody forgot to hang up their phone after calling them. So, yeah, there is humor in this, but I think that demonstrates part of the problem is that there's a lot of medication out there, and while a lot of it's being used for very good purposes, working wonderfully, some of it in increasing amounts being diverted and abused. Law enforcement is seeing more of this too. Traditionally, they don't see a lot of diverted pharmaceuticals, but they're seeing more. On the overdose deaths, for the last 2 years now, we don't know why, but fortunately, we've seen after a steep increase over the last several years in both the non-heroin, opioid, and the heroin overdose deaths, we're starting to see a decrease, or at least it's come back down. Our numbers, again, pale in comparison to other states, but it shows that trend line that I was talking about. We hope this is the beginning of a new trend where it goes down, but we don't know. And this could be more effective treatment, a quicker response, greater awareness, where healthcare professionals and others, including parents in the home talking with kids, are starting to make changes. Same thing with heroin and law enforcement. They hardly were seeing it, now they're seeing it a lot, especially in eastern Iowa. Naloxone is the opioid overdose reversal or rescue drug that's being used on an increasing basis. Iowa law just changed on this, and it's still kind of a work in progress to allow law enforcement, firefighters, and virtually any citizen in a position to assist to possess and administer naloxone with immunity from liability if it's in good faith effort. Prior to now, and what this chart reflects, largely would be used by EMT and emergency room personnel, because they've been the only ones who could really use this on opioid overdoses. Even our prison admissions are being affected by this because of the diversion, the criminal activity that goes along with somebody trying to profit off of somebody else's addiction. Again, I'm going to skip over some of these in the interest of time. These are just a couple of web pages that anybody who wants to know how to get high can go to. The point here is that if you're a parent, grandparent, loving family member of a young person, these are sites I, as a parent and grandparent, I would not want my children or grandchildren going to, because it's all about what's the best way to get high. And this is what we have to counter from a parental and prevention standpoint. At the bottom here, a reference to the 2 law changes this year. One was that increase in access to naloxone to try and reverse some of these overdoses and save more lives. The other is involving the prescription monitoring program, which is, as I view it, it's Iowa's air traffic control system for prescription medications, controlled prescription medications, 2s through 4s. And that that system can be merged with electronic health records to reduce the amount of time it takes healthcare professionals of record to look to see, when I go in and see my doc, or I go in to get my meds at the pharmacy, what else am I taking? And if it's the 5th time in the last 3 weeks that I've gotten hydrocodone from a different doctor, I wonder if I really need that. We also we want to work from our office on policy and practice on reducing the supply of abused opioids, including the prescription variety, but we also want to work on the demand or consumption side. Each of us as patients or consumers have a responsibility too. So we are working increasingly on taking back or properly, safely disposing of medications, not only for health, but also environmental reasons. Nationwide, there's more of this happening. More and more unused meds are properly being disposed of, and that's true here in Iowa too. And oh, by the way, October 22nd, 2 or 3 Saturdays from now, will be the next National Prescription Drug Take Back Day. So watch for sites, go to the DEA website, and you'll find where you can go to dispose of your meds if you don't already have a permanent site in your community. These are the permanent controlled prescription drug drop-off or take-back sites that we know of in the state of Iowa right now. This is a kind of a convoluted work in progress where we have law enforcement agencies and we have pharmacies that are participating, but still relatively few when you look at the number of communities across the state. So We want more people to do that because if they're not in the medicine cabinet, they're less likely to be abused. And we know that over half of the people who say they abuse prescription medications say they get them from family and friends. So yes, it can be doctor shopping, but it can also be stealing or buying from family and friends. So we need to get that out of the house. On the prescription monitoring program, or PMP, Iowa's one of the many states with one. This just tells you a little bit about it. I'm not going to go into the details here right now. But we have seen some indication that the more it's used by those healthcare professionals, because it is a patient care tool first and foremost, the less suspected cases or fewer cases of doctor shopping are detected. So it appears to be a tool that works. We're hoping it will be used more so it will work more effectively. This just shows you what you probably already know. There are a lot of opioids going out, prescribed and then dispensed. In the box there, I think, is a striking stat where we make up a very small part of the world's population, but boy, we are good at consuming pain pills. We either are doing something really right and better than everybody else, or at least we're doing it differently because we are consuming a disproportionate amount of the opioid medications in the world. And of the hydrocodone, we take about all of it. This is registrations to use that prescription monitoring program, the electronic database. But it's only being queried about 7% of the time. I don't know what the right number is. This is for the experts to figure out, the healthcare experts who are using it. But it's like a lot of other things, this is another work in progress. This is what I mean about it is showing signs of effectiveness in trying to deter or reduce doctor shopping. It's an inexact correlation here, but this certainly looks better than what would be the case if it went the other direction. So we are making some progress. We're starting at a better point. It's a more manageable problem, but it is a problem nonetheless. It's one that's growing, we think, and it's one that it's affecting a lot of people. And among the challenges, I'll go back to the newer challenge in this relatively new issue are these non-medical synthetic opioids that are like the synthetic cannabinoids or the K2s you may have heard about, and the synthetic cathinones or bath salts. Now there's an opioid version of that in these fentanyl analogs, and people really don't know what they're getting into when they get that. So with that, hopefully, I don't know if I was long, not too long ago. I thank you, and I'll be around for questions a little later on. Thanks.
Well, good morning. My name is Craig Wren, and we thought that it would be a good idea, if we're going to talk about opioids, to talk a little bit about their mechanism of action and how they work. And so that's the task that I will be performing for you today. We'll mainly focus in the few minutes that I have on the mechanisms of analgesia and addiction. Those are the two most important physiological effects of the opioids. So, what we have here is a list of opioid drugs, and my purpose here is to provide a definition. Dale already mentioned that opioid is kind of a catch-all term. In pharmacology, when we talk about something being an opioid, we are referring to any chemical compound that exerts its physiological effects by binding to and activating a molecule that we call the mu-opioid receptor. So all of the drugs that you see in this table, whether they be naturally occurring substances such as morphine, which is derived from the sticky resin-like substance from the poppy plant, or whether they be synthetic compounds, they all work the same way by binding to and activating the mu-opioid receptor. So essentially all opioids work the same. One way they do differ, however, though, is in their potencies. So you can see from this table, we have some numbers relative to a 10 milligram oral dose of morphine. You can see there's quite a range of potencies. And potency is also significantly increased if you change the route of administration from oral to IV. So, for example, you can see heroin IV is 4 to 5-fold more potent than oral morphine. And then towards the bottom of the table, you see some very important agents in terms of the drug abuse problem. IV fentanyl is 50 to 100 times more potent than morphine. And then recently in the news in Ohio, street heroin has been found to be laced with an agent called carfentanil, which is traditionally known as an elephant tranquilizer because it is a very potent agent. In fact, it is 10,000 times more potent than a 10 milligram dose of morphine. Now, in order to understand the analgesic or pain reduction mechanism of the opioids, we need to review quickly just a little bit of neuroanatomy. And what's shown here on this slide is a diagram of the pain pathway, the pathway of neurons through which pain information is transferred from the periphery to the brain. So we have at the beginning of the pathway the so-called afferent nociceptors, which are the nerves that detect pain in the periphery. And then that pain signal is transmitted to the dorsal horn of the spinal cord via a connection that we in neuroscience refer to as a synapse. And then the information travels from the dorsal horn of the spinal cord up to the medulla, onto the thalamus, and finally to the cortex where we perceive pain. Now, the mu-opioid receptor is located in several different places in this pathway. But in order to understand the mechanism, the best part of the pathway to focus on is the synapse, or the connection between the primary afferent nociceptor and the dorsal horn of the spinal cord. So we'll focus on that location in the next slide. So here we have a blown up or magnified cartoon view of the synapse, or connection between the afferent nociceptor on the top and the neurons of the dorsal horn of the spinal cord on the bottom. And I like to refer to the opioids mechanism of analgesia as being kind of a double whammy event. And that's because there are two things that need to happen for pain information to be transmitted from the afferent nociceptor to the spinal cord. The first is that in the afferent nociceptor, chemical signals called neurotransmitters must be released, and it's those signals that convey the message to the neurons of the spinal cord that there is a painful stimulus. The second event occurs when the chemical transmitter relays its message to the neurons of the dorsal horn. The electrical activity of those neurons is increased. So those are the two events, and we refer to them as presynaptic and postsynaptic. The presynaptic event being the release of neurotransmitter, and the postsynaptic event being the increase in electrical activity in the dorsal horn neurons. So opioids have a double whammy mechanism. They're very powerful because they address pain transmission in both locations. So at the presynaptic location, when the opioid compound binds to its mu-opioid receptor, which is kind of seen there at the top, the squiggly line at the top right of the presynaptic neuron. That's the mu-opioid receptor. And when the opioid binds there through a cascade of biochemical reactions that I will not burden you with today. If you want to talk to me about them later, I'm happy to do that. But through this cascade of biochemical reactions, the consequence of opioid binding to the mu-opioid receptor is decrease in release of the neurotransmitter, decrease in the chemical signal, the chemical pain signal. Furthermore, the mu-opioid receptor is also located postsynaptically on the dorsal horn neurons. And when opioids bind to the receptors in that location, through a cascade of biochemical reactions, the effect is to diminish the electrical activity of those dorsal horn neurons. So, presynaptically, we have an inhibition of transmitter release by the opioids, and postsynaptically, we have the inhibition of action potentials or electrical activity. So these agents are very powerful pain relievers because of this double whammy mechanism of action. Now, if you're interested in decreasing pain, this is very exciting. And the opioids are very potent agents and very good at providing analgesia and pain relief. The problem is, and this is a common problem in pharmacology, is that the mu-opioid receptor is not located just in the pain pathway. but it's also located in other parts of the brain. This is relevant to the phenomenon of addiction or abuse of a drug because the mu-opioid receptor is expressed in the so-called reward circuit of the brain, this is actually a simplified version diagrammed here at the bottom. The mu-opioid receptor is located in various locations in that pathway. Now the reward circuit, to understand what it is, it motivates survival type behaviors. Eating, drinking, sex are two prominent examples. And the reward circuit plays some kind of role, or at least activity there is associated with the subjective feeling of pleasure. So these survival type behaviors, the things that organisms need to do to either survive as an individual or for the species to survive, have a subjective sensation of pleasure attached to them, and that serves as a motivator to engage in those behaviors. So some people, and I like to refer to this circuit as a survival circuit. I think it's a good way to think about it. Opioids enhance dopamine release in the survival circuit. And we've learned that dopamine release in the reward survival circuit is important, or at least associated with providing the subjective feeling of pleasure and motivating or driving the behavior, whether it be eating, drinking, or sex. So what happens in opioid abuse is that the opioid hijacks this system and causes dopamine release just like any of these other survival type behaviors. So what happens is that the person who is abusing the opioid is driven by a survival-like compulsion that they have great difficulty controlling to use the drug. And this is all because the mu-opioid receptor is located in this survival reward circuit. Now, in and of itself, maybe that wouldn't be so terrible, or at least not so dangerous. But the problem is that the mu-opioid receptor is also located in a third location. And that is in the medulla or brainstem neurons that control respiration, breathing. So what happens is tolerance develops to these euphoric, pleasure-like effects that come from using the drug. So the opioid user increases the dose, and this brings the individual closer and closer and closer to the dose that will inhibit neuronal activity in the respiration centers of the brain, and that's the proximal cause of death in opioid overdose, is the cessation of breathing. Now what I want to do next is run through a few important opioid agents that Dale has already mentioned and will be mentioned as we move forward, and make sure we understand what those agents are and how they work. So the first one here is heroin. We tend to think of heroin as a special case, but I would point out that we only think of it as a special case because of its legal status. It works just like any other opioid, and in fact, its activity requires enzymatic conversion to morphine in the brain. So heroin is really just a morphine prodrug. Because of its chemical properties, it enters the brain very quickly, which promotes its euphoric effects. And once in the brain, it's converted to morphine, and it's really morphine that does the action in terms of heroin's physiological effects. Because it enters the brain so fast, and because it's usually used IV, it ends up being 4 to 5 times more potent than morphine. Now, naloxone, they already mentioned naloxone and how Iowa law and other laws across the nation are making naloxone more available. I think this is very important in terms of public health. So naloxone is what we pharmacologists refer to as a competitive antagonist. So the way that it works is it also binds the mu-opioid receptor, but it exerts no effect when it binds. It just sits there, like my old pharmacology professor used to say, like a bump on a pickle. It doesn't do anything. It just sits there. But what naloxone can do is it can compete with the opioid that the individual has overdosed on. And so whenever naloxone binds a receptor, the morphine, the heroin, the fentanyl can't bind, and that will bring the person back from overdose and wake them up, essentially, and get them breathing again. And it does this because it can outcompete the opioid agents. But the important thing to know, for all clinicians to know, is that the duration of action of naloxone is quite a bit shorter than the opioids, than the opioid agonists such as heroin or OxyContin or morphine. And so the naloxone needs to be given. So if a third party gives naloxone to their friend who is overdosed, the next step is to go to the hospital so that they can be monitored, and the naloxone can be dosed again, which is usually necessary to do until the opioid has been cleared from the body. Methadone is an agent used to treat opioid abuse, and to be very brief here, there are some properties of methadone that make it ideal for this situation. Not only does the opioid abuser use the drug in pursuit of the euphoric effects, they also use the drug to stave off the very unpleasant withdrawal symptoms that are present when they attempt to abstain from the opioid. So here on these two graphs, we have on the y-axis intensity of drug effect and intensity of withdrawal. And you see that with IV heroin, we have a very quick, developing, very intense euphoric effect that then also disappears quickly, leading to withdrawal within just a few hours. What methadone does is it stimulates the opioid receptors when taken orally, but it gives a smaller effect and a longer lasting effect. So methadone can prevent the withdrawal symptoms, but doesn't provide as intense of a euphoric high as heroin. So it allows the person to be functional. They're not obsessed with finding the opioid because they're not experiencing the withdrawal symptoms. And so they're able to be maintained on methadone therapy and go to school, go to work, perform daily functions of life. Another agent that can be used to treat opioid abuse is Suboxone, which is a combination of buprenorphine and naloxone. Buprenorphine is a partial agonist of the mu-opioid receptor, which is just a pharmacologist's way of saying that it doesn't give as intense of an effect as a full agonist, such as morphine or fentanyl. And buprenorphine has a slow onset and long duration of action, similar to methadone. So it can be used in a way similar to methadone. And the naloxone is there just to prevent diversion. If you try to if an individual tried to divert the Suboxone and sell it to someone to use for IV, it wouldn't work to provide the high because the naloxone is there to outcompete the buprenorphine for the mu-opioid receptors. So that is a very brief summary of the mechanism of action of the opioids, and with special attention to some specific agents. These are the main points that I hoped to make today. All opioids are effective analgesics because they act on the opioid receptors. But these receptors are also present in the reward circuit, which it hijacks, leading to compulsive use of the opioid. Overdose can be treated with naloxone, which acts by competing with the opioid agonist for the receptor locations. And then opioid use disorder can be treated with methadone, and that's due to their slower onset of action and longer duration of action. So thank you very much for your attention. I hope I've stayed on time so we have time for questions when we're all finished. Thank you very much.
Hello again, everyone. Again, I'm Frank Calgary. I'm a professor here in the College of Pharmacy. And my colleagues and I, we've done several talks on the opioid and heroin crisis. And so for today's talk, I thought it would be good to take the angle of harm reduction approaches, kind of building off the naloxone that was mentioned, these recent laws, and then some of the medication-assisted treatments that you just got introduced to, such as methadone and buprenorphine. And so that's going to be the approach I'm going to take. Hopefully they give us some actual additional practical things, as this law will be likely implemented by the end of the year. And so every citizen, every member of our community will have a larger role in helping to address this epidemic. So just to get started, I wanted to touch on some of the principles of harm reduction, because what's happening here is we're trying to get over the stigma that's been created through the substance abuse disorders that have been created with usually the initial prescription opioid and then subsequently onto heroin. And so this is a good resource. The citations here at the bottom, and this is from the International Harm Reduction Agency. And so if you're interested in this topic at all, I encourage you to start with this document, but they touch on sort of the 5 major themes of harm reduction. And so pragmatism is just an acceptance that we're never going to end or eradicate all drug abuse. Humans have been using mind-altering substances since the beginning of time, so this is nothing we want that is going to go away, but we should take an approach to more containment. The second one on humanism is just to acknowledge and respect the dignity of every patient who may be using or abusing these substances. They are still humans, and we need to do our best to help them with that addiction that they found themselves in. The cost-benefit ratio is a little bit more difficult to analyze because there's a lot of variables involved in that, but this is looking both at the cost and benefit of harm reduction, not only to the individual, but to society as well. And then prioritizing problems. This takes a look at the approach of hitting the target groups or those that are at highest risk for complications or harms related to drug abuse. And finally, the harm focus, which is sort of these principles here, is not only is the patient abusing and addicted to a substance, but there are also some real risks that come along with IV drug abuse specifically, and hence the harm reduction approach is used to sort of diminish the incidence of these findings. The best example of harm reduction that's out there in the world is needle exchange programs, which we don't necessarily have here in the United States, but that's the classic example utilized. And so the biggest harm that we're looking to prevent is death from overdose, as we've talked about with the increasing incidence. And so I know Dale's already covered a lot of these statistics, so I don't intend to recover them, but I just want to highlight the sharp graph curve with the 286% increase from heroin overdoses. And then also the box in the red just really highlights how this is affecting all populations, all subclasses, all socioeconomic classes, privately insured, publicly insured, you name it, heroin is affecting those demographics. And so why this is such a huge issue and why everybody has a role to play. In terms of looking at what has led to this heroin epidemic, I think the best paper I've read on the subject came out this January in the New England Journal of Medicine by Dr. Compton. And what I found pretty interesting about this is that the increase in heroin use has been kind of tracked to 2007. And what is interesting as a pharmacist is that this is before we have implemented sort of abuse deterrent formulations. And so there was a thought process that as we created abuse deterrent formulations that could not be crushed or injected or snorted, that was what led patients to seeking out heroin to replace those avenues of opioid use. However, this paper does a really good job at looking further into what's really happening, and what happened is essentially those communities that were hit hardest with the opioid abuse epidemic, mostly in the southeast of the country, as you saw on that map, have also been targeted by heroin traffickers and heroin dealers. And again, it's really the affordability, as Dale mentioned, that's really been driving this heroin epidemic. So developing abuse deterrent formulations is still something the FDA is promoting and that we're doing, and any little bit helps, but it certainly won't solve the problem of the heroin epidemic. So as we're seeing more and more heroin, I think it's important just to look at the numbers because I find them startling. So current users defined as within the last month is up to nearly 500,000 Americans, and that's up from just over 150,000 in 2007. However, other estimates look at current users as defined by within the last year, and if you use that definition, you're getting closer to 1 million users of heroin who are putting themselves at risk for all those harms that we previously mentioned. And then Dale mentioned how many patients start with opioid abuse, and that is true. About 80% of users of heroin, their first introduction to an opioid was a prescription opioid. And 2 studies have kind of looked at what is the risk of developing a heroin addiction following non-medical use of an opioid. So again, not something you're supposed to be using, but that's being used recreationally. And both those studies found numbers around the 4%. So of course that's not a very large number, but when you consider the tens of millions of users of non-medical prescriptions, this is how we end up with numbers closer to the 500,000 or 1 million person range in the state, or in the country. And as we've talked about overdoses, a lot of focus has looked at the prescription drug overdose, and so you can take about 18,000 deaths annually and add another 10 to 12,000 from heroin specifically. So those are usually counted separately. The total combined is upwards of 40,000 deaths per year. And one of the other things that's been interesting with this heroin epidemic is the different routes of administration. Heroin in the 1980s was reported by the DEA to be around 10% pure. That purity has risen to between 30 and 40%, and this allows different routes of administration. And so for the average person who has developed a dependence on opioids, something like injecting a drug may not be appealing to them. However, these alternate dosage forms, routes of administration, such as snorting or smoking, can help bridge that gap for users, and that's what's led to an increased use overall. This increased purity is allowing people to use it in a different fashion, and then that may ultimately lead to IV drug use. And fentanyl has been mentioned quite a bit here, but again, it is such a hot item in the news. As as mentioned in Ohio, many overdoses due to this. And the one thing I would like to highlight is this is dosed in micrograms. So if you're a healthcare professional, you have an appreciation for that. So when I show you this next graph that we got from our colleagues at the DEA that shows about fentanyl seizures and synthetic seizures, just appreciate these are kilograms of seizures being seized by the DEA, but it's just micrograms that the doses are. So this is millions upon millions of doses of these drugs. So in order to stop this epidemic, it's definitely on multi-level fronts. Prevention is key. Reducing the heroin addiction by treatment programs such as methadone or buprenorphine that I'm going to touch on here and Dr. Grady is going to pick up with. But the focus I'd like to take is on the naloxone. As mentioned, this is going to be, the law has been passed. It will be implemented likely by the end of the year. So this is something you will certainly hear much, much more about here in the state of Iowa. And so around the room, I have a couple signs. These are from the CDC. And the CDC this year really took an aggressive approach to combating the opioid crisis. They put out a new guideline for prescribers to help augment the number of prescriptions that are out there. The number of prescriptions, as you can see on this poster here, is that they've gone up fourfold since 1999, but pain has remained the same, and deaths have accounted for roughly 165,000 deaths in that time period. And so the CDC is calling this an epidemic and comparing it to statistics such as 500,000 deaths in the Spanish flu epidemic or 500,000 deaths that we saw in the peak of the HIV or AIDS crisis. So it's pushing up towards those numbers, and hence why there's such a huge push to try to tackle this, not only from prescribing, but again from harm reduction and safety approaches. So again, I would encourage you to check out the CDC. There's a whole list of resources out there. Some of these may be applicable to your setting or where you work, or even for family and friends. And so just briefly, I want to touch on what they found in their findings. Dependence is real. We're seeing it in ultimately nearly a quarter of patients who use opioids can develop dependence. This is a little bit less in the pain specialist field, but again, most of the primary care providers are the ones prescribing the vast majority of opioids. And we do know that the risk is definitely dose-dependent, and this is where drugs like naloxone come into play. The guidelines give about 12 recommendations for prescribers, and they're in 3 different areas, and I'm just going to focus on the last area for today's audience, which is assessing the risk and addressing the harms. So different things that have been identified from the literature as far as well-known harms. There are different disease states such as sleep apnea or patients with renal and hepatic insufficiency that allows the drugs to accumulate. But we also have identified certain patient-specific factors that put them at risk for death or overdose. One being a history of overdose in the past, substance abuse either within the patient or within the family, and then doses that are over 50, and this is MME stands for morphine mill equivalents per day. And so this is based on the oral morphine mill equivalents. Not much to meet this parameter, I'll just say that. And if you're a practitioner out there, you know that there are many patients maintained on much more than 50 milligrams per day. The other big recommendation put forth by the CDC guidelines is these other drugs listed here at the top: Xanax, Klonopin, Ativan, and Valium. Those are all brand names for what we call benzodiazepines. They also lower respiratory drive and can contribute to respiratory depression. And what we're finding in the vast majority of deaths due to these substances, it's usually from a combination of them. And when I pass it over to Dr. Grady, she's going to pick up and talk to you guys more about the medications that are approved for opioid use disorder. We currently have 2 primary. Methadone is the one that's been around the longest, but sort of the new kid on the block is buprenorphine, most commonly referred to as Suboxone. And if you're interested as well, there's a great review article this year in the New England Journal that provides more of a background on how to utilize these agents. Just in the interest of time, I'm going to skip over this, but there was a recent law passed to expand access so more patients can be on Suboxone as a maintenance therapy. And there are 71 prescribers here in the state of Iowa and resources to identify those if you identify a patient or family member in need. But really, I'm just going to use the last few minutes to focus on the new Iowa law. It was signed into legislation by Governor Branstad in March of this year. And as Dale mentioned, the big thing for this audience is that we are all now considered a person in a position to assist. And so with that said, we will all have access to naloxone to be used in an emergency setting if we seek that out, and there are 40 other states with similar laws. This is the verbiage, but for the pharmacists in the audience, just appreciate that any licensed pharmacist, by a standing order, means that we can dispense these to not only fire departments and emergency personnel, we must provide instruction on how to use those, and then we must also provide instruction to anybody in person in a position to assist. So then again, all of us in this room now fit this criteria. If we're ever in a situation or we know of people who are at risk for opioid overdoses, we may be seeking out naloxone prescriptions. In the interest of time, I'm going to skip over this, but there are toolkits available out there on what to do in an overdose, so these are real practical things you can consider. And what you'll be seeing a lot more in the future are what are called naloxone kits. Many healthcare organizations have started to put together these kits that are all-encompassing in terms of what you need to help somebody with the initial overdose before getting them the emergency response team or getting them to the hospital. They include different formulations of naloxone, and you should always give 2 doses. As we've talked about, it has a very short half-life and may wear off. And so in closing, I have some of these, and we can talk about them later, but these are all the different dosage formulations. I just want to highlight the third one on the top, which is a nasal administration, which will make it very easy for anybody with a fear of needles or anybody that feels uncomfortable for administering the antidote to sort of have a little bit increased level of comfort as you're just going to be spraying the antidote into their nostrils. So with that said, time flies by quite rapidly. So in summary, this naloxone law has been approved. It approves third-party persons in a position to assist. You will certainly hear more about this. This may be a potential project for any students in the audience to work with high-risk populations in the development of these kits and tracking their utilization. So with that, in the interest of time, I'm going to turn it over to Dr. Brady.
Good morning. Thank you for attending. I'm going to talk a little bit about the clinical presentation of opioid use disorder as well as treatment options. There are treatment options for addiction. I see addiction every day. I interact mainly with those that are going through opioid withdrawal, and it's not pleasant. It's not pleasant for the person. It's tough on us, the providers. It's hard for us to watch this, but there are options. And one of our main jobs at Bravo's is to get people into treatment facilities. So I want to underscore that point. There are treatment options for anyone that has an opioid use disorder condition. The other thing I want to highlight is that opioid use disorder it can affect anybody. I've met doctors that have it, pharmacists, nurses, lawyers, police officers, firemen, politicians, judges. It's not relegated to a certain gender, a certain race, a certain age. So I just want to underscore those points, and that there is treatment. Because a lot of times people don't want to come forward to get treatment because of the stigma. So my main role as a pharmacist is to help people be supportive and encourage them to get treatment. So let's talk a little bit about opioid intoxication. This is going to look a little bit different on everybody, but this is what may occur. So people can have constricted pupils. Obviously, they can have euphoria, and that's what drives the use sometimes. Decreased respirations, a low heart rate. Even though opioids can make people feel good, it is a central nervous system depressant. So it can stop your breathing, stop your heart, and this is how people pass away. So opioid intoxication can be fatal, and this is why it's great that naloxone, which is the treatment, as the other gentleman had mentioned, it's great that it's expanded access now because a lot of people are passing away from this. A lot of times accidentally. A lot of times people are just in such bad emotional, physical pain that they up their dose, and soon they can't breathe. So it's great that we have it. Now, when you administer naloxone, when we've given it in the ER, sometimes what happens is people come out of it quickly and right away. I'll never forget the first time I saw that as a pharmacy student. I was on an ER rotation, in a Cook County hospital in Chicago. And the naloxone was administered, and you can see that it's administered through several different routes, intramuscular, IV, subcutaneous, intranasal. I'll never forget, the physician administered the naloxone, and the person literally, woke up, so to speak, right away. It kind of frightened me because I hadn't seen that before. But thankfully, the person was okay. And what happened is they went through withdrawal. Withdrawal is just the opposite of intoxication. So instead of being high or having a high mood, someone's going to have dysphoria or a low mood. Instead of being tired, they're going to be wide awake. And, they can have high blood pressure, and they can have increased respiration. So it's just the opposite. And as I mentioned already, I see withdrawal every single day. And it's very, very tough for people. And people tell me, Sarah, I want to stop using, but I'm so scared of the withdrawal. A lot of times that is why people keep using heroin. The majority of individuals that I've met do not want to keep using. They want to stop, but they continue to use because the withdrawal is awful. Now, the withdrawal will not kill you, but people tell me it's so uncomfortable, it's so tough. They tell me it's the worst case of flu times 1,000. They feel very badly, and this is what a lot of times fuels their use. They don't want to use anymore. So I want everybody to kind of keep that in the back of your mind. So treatment of withdrawal, here's the other thing about withdrawal. Withdrawal, depending on what people are using, if it's heroin or something like hydrocodone, oxycodone, the symptoms of withdrawal occur pretty quickly, like 4 to 6 hours after the last use. If they are misusing something that's a little bit longer acting, such as methadone, then the withdrawal symptoms won't show up right away. But as I mentioned, the withdrawal is not fatal, but people feel like they want to die. And a lot of times that is what fuels their addiction. Not chasing the high, preventing the withdrawal. So of course, we have management for withdrawal. At Heartland, we use medication called clonidine, which is actually for blood pressure, but it can really help decrease the symptoms of withdrawal. As I mentioned, a lot of times people that have withdrawal, they have high blood pressure, a lot of nausea, vomiting, diarrhea. So clonidine can certainly help with those symptoms. We also provide some supportive care. So people that are in withdrawal a lot of times have diarrhea. So we give them a medication, a loperamide for diarrhea, and they're in pain, right? Because remember, opioids help pain. So when you take it away, and you take it away abruptly, people can be in a lot of pain. So we give them NSAIDs and Tylenol. Trazodone is a medication that we use for sleep. Remember that opioids can make you tired. You take it away abruptly. People have insomnia, so we provide some trazodone. And hydroxyzine is a medication that we use for anxiety. Remember, opioids can help anxiety. You take it away abruptly, the opposite can occur. So we want to make our patients as comfortable as possible while we are planning their treatment, their individualized treatment. So this is the criteria for all substance use disorders. You can put in opioid use disorders there, you can put caffeine, you can put marijuana, you can put alcohol, same criteria. And an individual only needs to have 2 of these criteria over a 1-year time span in order to be diagnosed with having a use disorder. If you have 2 or more, you're considered to have mild use disorder. If you have 4 or more, that's considered moderate. If you have 6 or more, that's considered severe. What I see every day is definitely severe. So people, substance use in greater amounts than was intended, people can't cut back. And as I mentioned already, a lot of times it's to avoid withdrawal. People can't control it. The craving is really bad. And of course, it interferes with all aspects of one's life, as we would expect. These are just some guidelines. At Broadlawns, we treat the individual, not the guidelines. So these guidelines are not going to apply to everybody. We work with everybody individually. But you can see, these are from the American Psychiatric Association. Obviously, the treatment for intoxication, as we already mentioned, is naloxone. For withdrawal, they recommend methadone and buprenorphine. We usually go with the second line option, which is clonidine, just because there's some legal issues with methadone and buprenorphine. And this is a different set of guidelines, and a lot of times the guidelines contradict one another. That's why we treat the patient and not the guidelines. But you can see here, the alpha-2 agonist, that's the drug class of clonidine. So clonidine, they have the first line option. So treatment. Again, I want to underscore there is treatment options available. And non-pharm is as big as pharmacologic. Anyone that comes to Broad Lawns, and again, most people want to get clean and sober, we have a chemical dependency counselor on our unit that meets with people individually, and together they develop a treatment plan. There are many treatment facilities in the state of Iowa, including one here in town. So a lot of times people are referred to those facilities, and they work on managing triggers and some other issues too. And of course we have pharmacological treatment as well. We have methadone, and here in Des Moines we have 2 methadone maintenance treatment facilities. And essentially what happens is the individual goes to the methadone clinic every day, usually very early, about 5:30 in the morning. They're given a dose of methadone. They take the methadone. They come back every morning. A lot of times they're required to attend groups and provide urine drug screens to make sure that they're actually taking the methadone and not taking other things. Okay, so there is criteria for both clinics. As Gary mentioned, Suboxone is another option as well. And again, we have prescribers pretty much all over town, including a couple at Broad Lawns. So a lot of this we've talked about already, and I'm not sure where I'm at on time. I know we want to, okay, we got a little bit of time, and I know we want to take questions. So methadone, again, methadone, your program has to be registered with the federal government. As was mentioned already, this is a full opioid agonist, and it does stick around longer in the system, as Dr. Rennan talked about. Some warnings, this can aggravate what we call the QTC interval, so it can have some heart issues. And the best candidates for this would be people that have had the opioid use disorder for at least a year or longer. So when it comes to dose, the dose is really individualized. What happens is it's dosed to basically the point where it reduces cravings and prevents withdrawal symptoms. And that's going to be different for everybody. That depends on what opioid you were using, how long you were using it, psychological addiction, many things come into play. So it is individualized. But usually it's started around 20 or 30 milligrams a day, and maybe lower or increase depending on the person. So again, when this is taken orally, it won't kick in as quickly as some of the other opioids, which is, I guess, a desired effect, but it will kick in and it will last a while. The other thing about methadone is that a lot of times patients will ask me, how long do I need to stay on the methadone? That is up to you and your provider. That's part of your treatment plan. I have known patients that have been on methadone for 20 or 30 years, and they're doing well. They haven't relapsed to other opioids or other drugs. They have jobs, they have families. In fact, you wouldn't even know that they go to the methadone clinic. Okay, so it can be continued for a while. And then I believe that most of this was mentioned, but buprenorphine, as Dr. Rennan said, is the partial agonist. So it does have a ceiling effect and is considered a little more safe than some of the other opioids because of its ceiling effect. And it comes in several different strengths, which is a good thing because the dosing with Suboxone is also the same with methadone in the sense that it needs to be individualized. Okay? And usually when people start this, they start it in a doctor's office or perhaps in a hospital setting like we do at Broad Lawns. And this is just the Drug Addiction Treatment Act of 2000. Qualified physicians and now nurse practitioners and others may treat patients in the office, and they have a special X in front of their DEA number to denote the fact that they are specifically authorized to prescribe this. So buprenorphine dosing can be a little bit tricky. Essentially, people have to have started their withdrawal already before you start the medication. If they are not in withdrawal, you can actually put them in worse withdrawal because buprenorphine kind of goes around, it likes the receptors and it bumps the other drugs off essentially. So people have to be in the start of withdrawal, and as I mentioned, withdrawal is very unpleasant to people, so you can see why this seems kind of counterintuitive, but this is the best way to administer and take the medication. So essentially, the first dose for most people is going to be about 4 milligrams, but again, that's going to vary depending on which opioid they used, how long they've been using it, and so on and so forth. And it usually takes about 20 minutes to a half hour, maybe a little bit longer to kick in, and those withdrawal symptoms are relieved. And then from there, they may need additional doses just depending on their cravings and their withdrawal symptoms. So again, everybody's going to be on a slightly different dose. From what I've seen in my practice, I would say most people are maintained on anywhere from 8 milligrams a day to 16 milligrams a day, and sometimes maybe 24 milligrams a day. And backing up to methadone, I've seen all kinds of different doses, but probably most people are on 60 to 80 milligrams a day of methadone, but sometimes it is a little bit higher. And since this is a partial agonist, if you dose it too high, people can actually go into withdrawal. So it's something to kind of keep in mind. Okay, again, I want to thank everybody for coming and questions.
So I'll just go ahead and open it up. Looks like we have a question in the audience, and I'll try to repeat these as well. So.
Okay. I had 2 questions. One is clarification for you, and then the other is for data wise. First, I was wondering about the Proxone kits. What is the distribution of that? Does it require a prescription? Who's going to pay for it? Things like that. And then the follow-up question was, as you mentioned, the American use of opioids and pain medication is much higher than the rest of the world. And I think one of the pushbacks or one of the counter arguments is that for physicians, we don't have any other pain choice. You know, people are in pain, we need to treat it. So what is the international use then? Because if we're using most of them, everybody's still in pain. What's used internationally?
So just to repeat the questions. The first one was touching on the naloxone kits, and the way that these will be legally accessible is essentially that a standing order serves as a prescription for everybody. And so essentially everybody has this standing order that when they walk into a pharmacy, the pharmacist references this standing order from the Department of Public Health, and that makes it a legal prescription for any person in a position to assist. So that's the naloxone kit. The second portion of the question was having to do with if we consume all the opioids in the world, what are the rest of the countries doing for pain relief? And so it was directed towards Dale, but I'll just make a comment as well from sort of traveling abroad and such. But essentially, NSAIDs and Tylenol and all the other stuff that we still have access to are just much more utilized in those settings. And opioids are really reserved much more for acute pain situations, traumas, fractures, things of that nature. It's almost maybe more of a societal thing that we have grown to use opioids as first line, and the other aspect that influences this is, as the CDC guidelines pointed out, they're not first line for chronic pain, but other interventions such as cognitive behavioral therapy, massage, stretching, physical therapy, occupational therapy at times are not covered by insurance programs, which leads to opioids becoming first line. And I'll just see if Dale, if you have any additional comments. And
I think you know more about this than I do, but there are a lot of pressures in this country that may be a little different than other countries. I don't know. You've got, not necessarily on this topic, but on some of the prescription drugs, you have a marketing machine that doesn't exist in other countries that essentially drives a lot of patients to the doctor to request, if not demand, certain treatment or medications. We're one of the few countries, as I understand it, that allows advertising of controlled prescription drugs. The insurance is one aspect. I don't know what the insurance system is like in other countries, but you have that. And that's a big piece, because I've heard physicians say that if insurance paid for water therapy, that's what I would be prescribing. So I think it's a combination of the money isn't, the incentives aren't there financially. Maybe they're there for the medication, not for the others. But also, I think you have patients, I use myself as a focus group, who have kind of been trained into thinking that it's a pill for any ill. And I don't have to go and do water therapy. I don't have to take the time to do the work or pay the out-of-pocket cost to do what might be required for some other form of treatment. So I think it becomes a path of least resistance for a whole lot of reasons, not just the professionals, but for the patients as well. And how that compares with other countries, that piece of it, I'm not that sure.
Thank you.
Question in the corner over here.
Thank you. Really agree with all your comments. I am a physical therapist and have been involved with our local Iowa chapter and the American Physical Therapy Association. The CDC and the American Physical Therapy Association have a campaign, PT First or Choose PT, because many individuals have musculoskeletal pain. Or they're laborers who are aging, who obviously have wear and tear in their joints and need something, legal or illegal, to keep working. There are many societal factors around this, but oftentimes after trauma, surgery, illness, sedentary lifestyle, working at your computer, those musculoskeletal injuries will respond to conservative care, but it may not be offered. So part of the education is to primary care physicians and specialists.
Thank you very much for the comment. I think many of you guys could give that. Yes, in the middle.
Yeah, I just had a question about kind of why this situation exists. We talked a lot about the treatment and how to deal with opioid addiction, but why has this spike occurred? And also kind of speaking to this similar point, Dale, the three different types of opioids, and those often, from a data perspective, get lumped into opioids. And so how do the demographic profiles or the risk communities vary among these two types of drugs?
Good question. So two-part question. How do the different distinctions between prescription opioids, heroin, and synthetics kind of play out in different communities? And then the other question is what kind of led to this epidemic? And so really it's multifactorial. There was a lot of things that occurred in the late 90s, early 2000s that led to this push towards opioid prescribing. Part of them were, there was initial research in the 80s. Believe it or not, in the 80s, many people thought that long-term chronic use of opioids would not lead to dependence, and there was publications that supported that, albeit small. Those were kind of picked up and ran with by big pharmaceutical companies and their marketing. Many pharmaceutical companies today are all paying fines or in the middle of lawsuits or litigation because of false marketing or promotion of these things or lessening their risk for addiction when they were marketing to physicians. There are other things as patient surveys. As patients are in the hospital in the setting I work and they leave, there are surveys that are conducted to ask how their pain was addressed. And so that has led to a big promotion in the inpatient setting for promoting pain. And of course, if you ask anybody if they have pain, you're going to say, yeah, especially if you're staring at a computer screen or whatever you're doing. That has been one of the other pushes. But again, it's been multifactorial. Then, of course, the societal push, as mentioned, in our current mindset as an American, is we often do go, as Dale said, for the pill. And so it's multifactorial between our culture, how we approach pain, what's an acceptable level of pain. Again, to Danielle's question about other countries, they have perhaps higher levels of acceptable pain, where here in the United States, it's often perceived that everybody must be at zero. So those are some of the factors, in my opinion, that has led to this. And the second follow-up question about the different dynamics, I'm going to pass that to Dale to see if he has some information.
I think the best answer is pocketbook. You have a lot of people who become dependent on opioids by taking pain medication for legitimate purposes, and over time, it doesn't happen instantly, but over time, in developing that dependency, by the time that's developed, they can no longer qualify for insurance, or the insurance stops paying, and all of a sudden, if they're going to continue that, if they can get it, those prescription opioids, it's going to be an out-of-pocket cost. And all of a sudden then, it becomes a consideration, what's cheaper? Heroin's cheaper today. That may not have been the case 20 years ago, but most of the time today, you're going to find it cheaper. And it's relatively available because, guess what? The profit makers who run the cartels who make this, they see this as a great business potential, profit potential, because their customers are being, well, the training wheels for their customers are the prescription opioids, and it's just creating more customers for them.
Thank you. I'm going to touch on a couple that have been up.
I just had a question about your map from 2002 to 2014. It was really interesting. I noticed that I'm from Blackhawk County, and it was red on the first slide, but then the second slide where it had gotten bigger, it was actually blue. So what are we doing right, I guess, up in Blackhawk County? Is there more enforcement, or what's going on here?
Well, Iowa's numbers are relatively small, whether you look at it on a county level or a state level compared to other spots. So it doesn't take much to change your color or your shade of color. As to what's happening right, I don't know specifically, but I think heroin's never been as big a deal in Iowa. It's certainly become one as of late. But I can tell you that when I go, I mean, it's kind of the same issue when I go to national meetings and I start sharing some of the Iowa statistics on this. My counterparts from other states go, well, why are you even here? So, is the glass half full or half empty? Well, it's both, I guess. If you are a family impacted by this, it certainly feels like a huge problem, and it is. But we have to keep it in context too. It is manageable to some degree, but we can't sit idle on it. So what's happening in Blackhawk? The same thing that's happening in a lot of counties, and the response, I think, has improved. We're getting better in a lot of ways. We still have a long way to go because there are a lot of other people in that addiction pipeline that we don't know about yet.
Thank you, and I would add the eastern side of our state has been most plagued by this. There was one in the back I wanted to get to. Yes.
What are the barriers to treatment? Economic, social?
What are the barriers to treatment for abuse disorder?
Right.
I think that probably be best for Sarah.
Thank you for the question. I would say stigma is the biggest barrier that I see. A lot of people want to get help. They're scared to come forward because they feel as though society sees them as a leper, and they also see that healthcare professionals also see them as a leper. So I say stigma is number one. I would say access, particularly in our state, is number two. But we are trying to address that. At Broadlands, we've hired 3 new psychiatrists, including another one with board certified in addiction. So hopefully we are changing things.
Yeah, I would just add on the access in rural areas, just like with a lot of other things, distance becomes an issue because while there are 71 prescribers, I think you said, of Suboxone, not every community has quick access. And part of that access issue is also payment. Insurance doesn't cover every one of those in a way that covers many other medications. So affordability. So we're working through that, but it's a process, and they're all barriers along with the stigma.
Just to touch on the stigma, there's a lot of resources out there looking at vocabulary. So how we refer to these things as it's no longer an overdose, but perhaps a bad reaction. Because as Sarah mentioned, oftentimes this happens unintentionally with elderly populations and drugs accumulating. So, Professor Rose.
We're starting to get into some of the topics here that are the topic of the day about social determinants of health. And there was a paper that came out maybe about a year ago, Angus Beaton and Case, they're a pair of economists in Princeton. And they were actually looking at death rates nationally for middle-aged whites. They're increasing. And they're increasing largely because people are drinking and drugging and suiciding themselves to death. So although I completely take your point about access to naloxone and similar kinds of treatment things, at the end of the day, an awful lot of this is being driven by unemployment, bad social situations, and things that the healthcare system is in no way prepared to deal with. And in fact, we have relatively limited national policy to deal with. So we could put Narcan in drinking water. This problem isn't going to go away until we look at some of that social stuff.
Yeah, it's a great point about addressing the social issues that are driving this, and I think Dr. Grady said it best with the stigma and patients just ultimately treating another underlying disease, whether that be depression, anxiety, unemployment. So absolutely, certainly an issue here. Yes.
I have a question about treatment with the older adults, so both the older adult who has realized that they need treatment, but also you're saying methadone can be 20, 30, 40 years. And I do see those older adults in the hospital, great discharge. What do we do?
Yeah, so in the older adult, we do want to be mindful that their body changes over time, and 60 milligrams of methadone might have been great for the first 10 years, but we do need to be vigilant of possible side effects that they may have, particularly sedation. So if people are overly sedated, then that dose may need to be adjusted. And also, sometimes older individuals have some heart conditions as well. And as I mentioned, methadone can aggravate those. So prescribers may want to check, an EKG and make sure, again, that the dose is not too high, because we believe that's a dose-related impact as well. Thank you.
I think we have time for maybe just a couple more, yes.
So we have about a 10-minute break, and please choose your workshop for the concerned session. And judges who are going to be judging the poster, you know who you are, purple ribbon. After lunch at 12:10, meet up at the stage. There's a stage in the lunch area, and meet up at the stage for instructions for judging. So, thank you, and let's see you next session.